going to start on time for our next topic, AI in primary care. Interestingly, primary care, other than radiology, has really seen the biggest uptake of AI in real deployment because of the role of ambient listening systems. And JC is from Rush. I vividly remember the day that Rush deployed ambient listening systems here in Chicago, because some of my former trainees are faculty there, and we saw the same thing happen all across the nation in the last year. So Virginia Irwin-Scott is a nephrologist, but she is in leadership at an organization called ChenMed, which is one of the largest primary care organizations, and she oversees the dialysis patient care through this large organization, travels the nation, really being very much a leader in primary care and nephrology. And she will be giving us this update in primary care. So I'm going to turn the mic over to my dear friend, Virginia.
Hi, everybody. So yes, I am a nephrologist. I was a practicing nephrologist for over 25 years, medical director with Fresenius, JV partner, led a nephrology division in the health system. After I got my CPE, my MBA, I got, recruited to go to ChenMed. So ChenMed is a primary care organization, 200,000 patients, full downside of risk Medicare Advantage. So I thought I knew population health well. I had 3,000 patients in my practice that were attributed to me, 4,000. And I really thought I understood population health and risk of progression of CKD and dialysis management. And I got into this role with ChenMed and realized I really didn't know population health at all. So as you start seeing numbers and statistics and you hear about where the future is heading, my population, 37% of patients have chronic kidney disease in the organization. So my population that I manage is about 80,000 patients, not just the ESRD. That would be so easy. So it's all of CKD. So 72,000 of those patients sit in stage 3B and above. That's primary care management. And that's really where AI in the future is going to really change the future of progression of chronic kidney disease by empowering primary care providers to be able to follow care pathways early. The federal government has given us HEDIS measures to follow, such as the KED measure, which is really to get clinicians to identify proteinuria. I don't care what the GFR is. It's 80, it's 90, it's whatever. But if there's proteinuria there and we're not doing anything about it at 88, we're not going to have the opportunity to slow the progression of chronic kidney disease, give patients 10 more years, and decrease heart failure by another 36%. So this is really where AI in the future, when you're talking about large language models, I love the idea of digital twinning and being able to know only 2 patients in 100 with CKD go on to ESRD. Do we need to give everybody GLP-1s? Do we need to give everybody MRAs? Do we need to give everybody SGLT2s? No, but we need to figure out the digital twin that shows you what the right medication regimen is for that patient going forward to slow that progression. So 2 Christmases ago, I decided I was going to get on this AI bandwagon. And I started out with doing a lot of reading and everything. My kids were home for Christmas. I have one child who's in medical AI. I have another pilot. I have a chemical engineer. And then my daughter, who was doing fintech programming at the time. She's like, she's my oldest, 28. She's laughing at me. She's like, seriously, Mom, you don't need to learn Python. You don't need to learn any of this. I don't know why you're wasting your time with this. This is just ridiculous. And I'm like, because I believe that this is the future. She's like, yeah, whatever. So she's in her programming world. She then decides to quit her job, as all these programmers do who live out in California. And she packed up her car and her van and lived, on the road for 18 months and, skied and climbed and did what they do. She then calls me and says, this is just recently, a few months ago, she calls me and says, hey, guess what? I got a new job. I'm like, what are you doing? She goes, medical AI. I'm like, what was that? You're doing medical AI? You're coding for medical AI? And she started laughing. She's like, yeah, okay, so you're right. The future is in that direction, and I get it. And now I'm moving in that direction. So again, no matter where we are in life, we influence our children, even as they are grown up, and it can help point them in the right direction. I'm going to also share, when you're talking about educating primary care and patients about the use of simple things like ChatGPT, right? So I had severe sciatica about 12 weeks ago, and I mean severe, thought I was going to die, never had pain like that before in my life. I started having a conversation with ChatGPT every day, giving my symptoms, letting it know how many steps I did, sharing some of my data from my activity trends, from my rings and stuff. And it plotted for me, showing me that I was getting better each day. I don't know that I could have survived without seeing activity of me getting better. I went to my primary care doctor because I thought I was going to need an MRI and everything. And I said to her, here's my ChatGPT care plan. This is what we're doing. This is the exercises I'm doing for PT. This is where I am in this journey. And this is the improvement I've had. So we can analyze this and we can decide together what my pathway should be. But again, having the ability to prompt properly, ask questions, and to teach patients that in the future, I think is going to be very, very critical. So much of what we've talked about, throughout the last 2 days, so many repetitive thoughts in many of the articles that I'm going to be reviewing. But just understand 30% of the world's generated data comes from healthcare alone. 30%. It's a lot of data that's out there. There are 500 million primary care visits a year. 52% of healthcare visits are primary care visits. How much of the funding for AI, machine learning, and all goes to healthcare? 3%. There's a huge opportunity for primary care to become a center point of focus. We're doing great in ICU, we're doing great in cardiology, we're doing great, but we're not really focusing a lot of the money and the time and the energy into developing primary care tools that a primary care clinician can use to predict risk and then to improve the outcomes and decrease total cost, decrease hospitalizations, decrease rehospitalizations, ways of knowing that medications are being filled. Vinod Khosla is one of the big VC capitalists in the country. Again, we were just talking about, where's the future? What should we be talking about in other meetings? His comments are, be a generalist in the future. He has his money on primary care as being the area of medicine that's going to get the most support, the most growth, and the best outcomes. You're going to have your curbside consoles sitting in your pocket. You're going to have a lot of the information you need to make decisions more readily available than you have in history going back. I don't know if anybody listens to Acquired podcasts, they're phenomenal, but they had an on-stage one last September where the CEO of Spotify and Zuckerberg were all on stage, and they talked about why is Spotify so popular? Why is Facebook so popular? It creates human connection. So why did Forward Health, that was creating a pod that you went into and all of your care was being done by AI, why did that fail? There was no human connection. So again, nobody's going to be replaced, but if you don't learn how to use AI in your everyday life, you will be, or I should say not in your everyday life, but as a clinician to improve the outcome of patients, that's where you're going to see that your partners who do will surpass you. Eric Topol, I just want to mention, please listen to his TED Talk, okay? Can AI catch what a clinician misses? It really was the talk we had in the nephrology room, the talk we've had in this room earlier today. Your primary care visit is going to start with a retinal exam. That retinal exam is going to give the list of disease processes that your primary care needs to really hone in on and talk to you about, and then get your plan for that next year. So again, there's a lot of conversation about this out there. Keep up with the data. Mel and I are big on LinkedIn all the time, following everything we can and sending it to each other. There's a lot of great information out there. I do want to say one last comment about stethoscopes. So as a nephrologist, I didn't live a day without a stethoscope. Even if I was changing a blood pressure medication for the patient, do you think I trusted anybody else to take the blood pressure? No, I'm a nephrologist. I took the blood pressure myself. And I think that part of that human connection, like we can give back clinicians time and we can make EHRs, better for clinicians and make healthcare better. But if you're a primary care provider, you need to still touch the patient. And I think a stethoscope is a great way to do that. So please don't abandon your stethoscopes. I did have a really cool one before I left that amplified sound and showed me the EKG. So yeah, I get that. But again, I think the stethoscope is still part of what connects us to that patient every day. So number one, scaling adoption of medical AI reimbursement from value-based care and fee-for-service perspectives. Background, widespread adoption of FDA-authorized medical AI remains limited. Reimbursement, we talked about that just now. Again, only CPT code that you can do for autonomous billing without having a human in the loop, diabetic retinopathy. 288 codes are being released for 2026. I looked it up just before I walked up here. Reimbursement is critical. It aligns the incentives among patients, providers, payers, regulators, and AI developers. Two primary models, fee-for-service versus value-based care. Again, fee-for-service, transactional. Probably the best way that this would happen would be more on a device or medication type payment method. Value-based care, again, reimbursement based on quality, outcomes, and population metrics. Methods, comparative analysis of fee-for-service versus VBC models regarding number one, alignment with adoption criteria, patient outcomes, equity, financial transparency, and sustainability. And then number two, regulatory and billing constraints. The identification of challenges and enablers via case studies. Again, this was the study that talked about diabetic retinopathy, autonomous AI as being the winning way of using an autonomous AI and having the billing available to get the claim paid. Proposal of a novel hybrid reimbursement approach for Medicare Part B cost plus model. I don't know if anybody, so those who are nephrologists in the room know what TDAPA is. That would be a similar type payment model. So widespread adoption of FDA authorized medical AI remains limited. I think we've heard that a lot in the last 2 days. Reimbursement is critical. It aligns incentives. So key results. Fee-for-service creates transparency and financial predictability versus CPT codes, but requires strong evidence for outcomes, equity, cost effectiveness, and few AI systems at this point are yet to meet that criteria. Very high administrative burden and slow adoption. VBC, on the other hand, taps into population metrics, MIPS, HEDIS, much easier to integrate this type of AI system, but financial gains are all or none, right? Based on whether or not you're hitting the threshold. Again, ChenMed, downside of risk, Medicare Advantage, we are in that all or none world. You don't get partial credit. Incremental improvements may yield zero reimbursement, which discourages innovation. The hybrid cost plus model, AI services price based on an average cost plus margin revenue shared between payers and developers. And that's kind of like that TDAPA in the nephrology world, where in the dialysis, if a new medication comes out or a new technology comes out, you can bill for that additional technology outside of the bundle, and then you get like an administrative fee on top of it. That's what this type of model would look like. Over time, usually gets built into any type of bundled program, and then that TDAPA amount falls off. Could balance utilization risk and it could balance utilization risk and scalability through but CPT codes must be created. So again, as we've been talking about, the creation of CPT codes that are specific to AI-driven technology is going to be critical. So conclusions, sustainable reimbursement is fundamental to scaling medical AI. Without it, broad, real-world impact will be unlikely. Neither fee-for-service nor VBC fully supports AI adoption alone. Hybrid models, though, do offer some promise. Key criteria for reimbursement, again, aligns with incentives across stakeholders. It needs to be financially beneficial across the board. We also have to be careful that we don't, entice for overutilization and increase the cost of care. Ensure financial transparency, minimize administrative complexity, and it must provide performance visibility for all decisions. Innovating reimbursement models like that Medicare Part B inspired hybrid is probably essential to unlock the AI's full healthcare potential in this space. Next article, does AI-powered clinical documentation enhance clinician efficiency? Longitudinal study, this was in New England Journal of Medicine, November 22nd, 2024. I don't think we're going to be surprised by the results here. AI scribes like Dragon, DAX generate clinical notes in real time with the idea that they were supposed to reduce provider burden. Earlier trials show mixed results. They reduce the mental load, but there's inconsistent gains saved in time. And they were calling at that point for a large-scale longitudinal evaluation of AI scribe impact on clinician efficiency and metrics. They did a longitudinal observation design, 112 primary care clinicians. This was done at Atrium Health, using DAX from June through August versus a matched control group. They were looking at both the outcome of documentation time, after hours work, and then also looking at it from a revenue perspective. They defined active users as those who did, 25% of the time were transferring their notes this way, or high performers were those that were hitting greater than 65%. Key results is, again, we've heard this several times in the last 2 days, no significant difference in the primary measures between DAX and the control when adjusted for the confounders. Subgroup findings, most reduction, and this was brought out yesterday in one of the lectures, it was the low volume clinicians and family physicians that had the best outcomes at the end of the day, but again, they were not meaningful. The clinicians do report reduced mental burden despite no overall efficiency gains. Again, I think it's important, even though the ROI may not be there, treating the mental health and the physician, burnout is still something that health systems need to take into account when they're looking at, these solutions for the future. Conclusions, AI-powered documentation did not significantly improve measured efficiency at scale in this primary care study. The subgroup benefits suggest potential value for certain clinician types. Improved clinician experience, lower mental load may still justify even without time savings. And we really need to do further studies and look at, where this goes over time. Again, I think there's so much data. This is 2024 study. If you think about how much you've seen on this just in the last 8 months, almost every week you're going to be seeing a new article come out looking at, these autonomous scribes. Especially when you look at what Epic is doing, you look at what Cerner is doing, and now building them into their systems. And again, most clinicians, the first thing they say is, how many more clicks is it going to add me? How much more time doing administrative stuff will it add to helping to make me better? Will AI make electronic health records more efficient for clinicians? Published February 2027, 2025, and this was New England Journal of Medicine AI. EHRs are near now almost universal across the US, improving care coordination, but have significantly increased clinician burden and burnout. I'll tell you, if you ask me, why did I leave clinical medicine and go into the administrative side? This is why. I could not deal with the, 500 inbox messages I was dealing with, the labs, and then again, you have the Cures Act, right? Patients get their results before we do, and we're trying to rush to get the, inbox looked at so that we're responding to them before they respond to us and ask why we're not responding to them. Because then you're also getting scored on how satisfied they are with you, right? So there's a lot of pressure on being any type of physician, but the inbox has added so much pressure. Surge in patient messaging via portals has exacerbated the workload. AI does promise an offer for some automation in message triage, draft responses, and ambient documentation. Methods and framework. This was an editorial synthesis of evidence from machine learning classifiers, routing patient messages with, either tagging urgent, refill, clinician message, nurse message, or AI-generated replies in EHR inboxes, and then the ambient scribe. So they were looking at different types of the different articles that have been written. Anderson et al., we're going to talk about his study next, did show that message triage does reduce office interactions with staff by twofold, and it did reduce the triage time by about 6 hours. Generative draft reply pilots reduce cognitive load. There's no significant time savings, but again, you're making the life of the clinician a bit easier. AI scribes, again, mixed results. We've talked about that. Some meaningful, but no efficiency necessarily gained. Message routing, clearer efficiency, fast response, less bouncing person to person in the office. Draft replies can improve mental effort, no consistent time savings. Again, we heard this morning, sometimes patients will prefer to get that draft reply from the AI. It's maybe kinder, it may have, a different sentiment to it. Ambient scribes, again, we talked about gains and consistent. Key enabling factors, you really do need robust infrastructure for a lot of this to work. Iterative refinement, role-specific customization as you're going through this routing and draft replies, and then patient transparency. Patients need to be aware that the responses are coming from an automated system. Conclusions, AI can improve EHR efficiency, but only when thoughtfully integrated into the workflows. Real gains are seen in message triage. Other tools offer mental relief more than time savings. Strong factors, success factors, again, strong infrastructure, role-based customization for teams, continue, modernization and feedback and making sure that the system is being updated as need to be, transparency to preserve patient trust. The editorial called for implementation science to invest in workflow redesign, to leverage AI for less clicks and less buttons to improve outcomes. Development and evaluation of a model to manage patient messages, portal messages. This is the Anderson article, February 2027, 2025, New England Journal of Medicine, AI. Background, clinician burnout from after hours EHR and pajama time. Again, we know it's not good. Manual inbox triage, inefficiencies and delays. They built an NLP trained model to help classify triage and to route portal messages before they hit the clinician inbox. This was done with Emory. Emory used a local product developer, and they developed something called MD Aware. It was trained on about 40,000 of their own messages within their system to get some of the nuances of understanding the responses and the different types of messages. So they developed this MD Aware model using clinician labeled data from patient messages integrated into the EHR at 4 Emory Healthcare outpatient settings, classified messages into 5 categories: urgent, clinician, refill schedule, or form. And then they compared rooted and unrooted conversations in a parallel control design. 97.8% classification accuracy of getting that message routed to the right place across the 5 categories. 80% faster resolution of inquiries, median resolution times down approximately 22.5 hours. 40% fewer inbox actions per message, read, replies, forwards. It reduced message handling burden and led to faster patient responses. So conclusion, a clinical trained NLP model can dramatically increase efficiency in portal message management, integration into workflows, reduce resolution time, handoffs, and the staff workload significantly, demonstrates real world viability of AI scaling, and to help relieve burnout. The next steps would be broader deployment, monitoring for miscalculations, and quality assurance. This is probably the favorite article of the ones that Mel and I talked about. Right care, right patient, or right place, first time, how AI is improving national virtual front doors. So virtual front doors, this is Australia, are patients' first contact via web or phone, designed to triage to the right care at the first interaction. Pre-AI systems struggled with personalization and often over-triaged, leading to unnecessary ER visits. AI integration into the Australian virtual front door aims to enhance consumer experience, equity, evidence-based care, capacity matching, and cost reduction. The commentary described deployment of AI-enabled symptom checkers across the national virtual front door platform in Australia. Highlights included symptom input, so it was free text rather than a hierarchy drop-down of picking symptoms. All triage logic was linked to live nurses as well as capacity data. So they knew where there was capacity in the system, where they had openings, if they were sending somebody in, urgent care, ER, et cetera. And it really emphasized the principle, of being able to get these patients to the right place, under the right time frame, and for the right care. And it did it with accountability and safety, and it watched for bias monitoring, shared governance, and it managed the rollout. 84% of consumers completed AI triage versus 49% before, 46% reduction in over triage to the emergency care, 55% of intended ED visits were safely redirected to lower acuity settings, and similar results have been seen in other international studies, such as the one in Portugal by Metis. They had a 48% reduction. So conclusions, AI-enabled virtual front doors deliver patient engagement and completion, more personalized triage, equity-enhanced access, better resource alignment with demand, and then cost savings through reduced unnecessary ED visits. Again, it is critical enablers, use-centric symptom input. They felt that was very important rather than having that drop down. Transparent use and governance structures, bias monitoring and performance oversight, and then thoughtful change management. The authors foresee AI as essential to a scalable, efficient triage model, helping deliver the right care, right place, first time. Data transformation to advanced AI ML research and implementation in primary care. This is an Annals of Family Medicine article, July 28th, 2025. AI and machine learning are rapidly transforming healthcare, with primary care being the largest delivery platform poised to have the most benefit. Yet progress is limited by the lack of well-organized, open, large-scale primary care data sets to support both academic and industry learning. So methods, this paper is conceptual rather than empirical. It recommends high-level considerations for transforming data ecosystems to support AI ML primary care. These recommendations include automating data collection, organizing fragmented data across systems, identifying use cases unique to primary care, integrating AI ML tools into human clinical workflows, and monitoring for any unintended consequences of ML deployment. So I'm just going to say, for people who are in the primary care world, the data is all over the place, right? Your structured data is there, you got your labs, you got everything else. Your unstructured data, it could be in different files and media files. It's very hard in primary care to have data sets that are clean and pulled together. I think that's what this article was really trying to come at. The other thing that we haven't really talked about is unintended consequences. So I sit on the CMS Measure Review Board for Patel, and one of the things when you're trained to be on that committee is learning about unintended consequences. So every time you do deploy a new system in your health system, it is really important to take a step back and to make sure we're recognizing what the unintended consequences are of some of these things that we are doing. Key outcomes: automation of data collection, streamlined capture of clinical, operational, and patient-generated data, organization of fragmented data, harmonizing the sources for usability and scalability, picking primary care specific use cases, focus on unique patient management and needs and decision contexts. And you want to be able to integrate this into the workflows that does not disrupt clinician care. I think that's the other important. We don't need to add to the burden. This has to be something that's going to enhance and support clinicians, not make it more difficult. Surveillance, again, of unintended consequences. Conclusions: transforming primary care data is essential for enabling meaningful AI machine learning innovation. With improved data infrastructure, organized, automated, and carefully integrated, primary care can spearhead healthcare AI ML to benefit patients, clinicians, and national health outcomes. Again, strategic innovation across all the stakeholders, clinicians, data scientists, policymakers, and technology developers to realize this vision. Last one, clinician perspectives on AI-generated drafts of patient test results and explanations. This was JAMA Network Open 2025. And it really was talking about 21st Century Cures Act, again, has accelerated patients' access to test results, increasing transparency, but leaving patients confused and anxious. Patients typically prefer results to be interpreted directly by clinicians. Generative AI, though, does offer the potential solution to ease patient understanding while reducing clinician documentation and burnout. So Stanford Healthcare developed and piloted an AI-based EHR integrated tool using Claude 3.5 to auto-draft patient result comments. The study design prospective quality improvement pilot conducted from January 13th to March 31st. Framework evaluated by the REAIM PRISM implementation framework and Squire reporting guidelines. Participants, 244 clinicians were invited, 38.1% completed the post-use survey. Tool integration was done in 2 staggered waves, and the completed surveys were 4 or 8 weeks. Usability and utility was measured, perceived time impact per comment, qualitative free text feedback was analyzed. Key outcomes: high usability, 84.9% of the clinicians found the tool easy to use. Utility across result types, laboratory results, 72% found explanations helpful. Imaging results, 63% found explanations helpful. The efficiency and quality, 71% perceived improved efficiency, 72% considered explanations higher quality than what they would have typically drafted manually. Again, the article highlights strong positivity towards usability, but suggests that there's still need for some iterative, refinement for this process. And I think the other thing you have to remember is only 38% of the clinicians opted into supporting and doing this. So again, I think with all of this stuff, when you're in a health system, rolling a project out and really making sure it's understood to get more than a 38% adoption is crucial. You want as many doctors to have input into what you're rolling out as possible. Positive reception, clinicians found AI-generated result comments to be user-friendly, utility enhancing, and of a higher perceived quality. No direct time savings, we've talked about that over and over again. Implications, early evidence suggests AI-drafted comment tools may support clinicians effectively and improving some communication experience. Broader implementation with refinement is needed going forward. So I think we're going to move on to the next speaker. I'll let you set it up.
Hey everybody, John here. Thanks for listening to another episode. If you enjoyed what you heard here today, please check out our website at www.americancollegeaim.org. Sign up to become a member. Also, save the dates, October 9th and October 10th, 2026. We'll be back live in Chicago, Illinois at the McCormick Place Convention Center for our second annual live scientific session. Sign up at the website to attend. Until then, we'll see you all on the next Melvin Monday. Thanks for stopping by. See ya.